we thought it would be sensible pre-Christmas, as obviously all of us working in the clinical setting know what's going on with flu at the moment. But I thought it was just worth pointing out that when what we're seeing nationally, this is the UK surveillance figures for the number of positive patients for flu admitted to hospital in the UK. And you can see for this year, 25, I was expecting it to go over to 26, that the flu season has come particularly early this year, starting in October, and is rising at a rate we often see, but it's certainly coming earlier than previous years. Obviously, we don't know exactly how high the peak is going to get. The other slight concern is that the flu strain circulating, there seems to be more of this H3N2 variant. And because of various mutations and so on, the vaccine may not be as effective as hoped. These mutations occur, and therefore there may be more sick patients this year compared to previous years. But I think we're still not seeing huge numbers in the intensive care unit or HDU. These are those looking at ICU and HDU admission rates. And again, you can see for 25, 26, it's following previous peaks, sorry, previous upticks, but we've not got to the peaks yet. But you could, certainly that's our concern, is that it's going to get higher. How high it goes, none of us knows. But it's why we need to be ready for it. It's coming. Obviously, it's frustrating. It's happening over the Christmas period rather than waiting till we could all have some holiday and then come back and tackle it. But we need to tackle it now. And so we thought we would just give you a quick update and show you how we're doing. Recruitment is progressing well. You could see the numbers of recruits building in October, November, and already in December. And I think this slide was done yesterday, and I think we've had a couple of recruits already today. So there are patients coming in, and obviously they're part of the global trial, and around 900 patients in the influenza stratum of the trial, and roughly half of them coming from the UK. So it's great. Again, as always, it seems the UK is recruiting well. So thank you very much for everybody for all you're doing. And here, hopefully you can see the names on the sites, or maybe it's better if you don't, I don't know. But just to shout out to those sites who are doing particularly well. This is just in the last few months, the number of recruits we've had. So well done South Tyneside, particularly. St Thomas's, I think you were one of the recruits I've seen recently, so maybe your figures are out of date. But Sunderland, UCH and so on are up there. Hopefully you can see yourselves up there, and if you're not there, hopefully you'll get there soon. And particularly a shout out to some sites who've just started recruiting more recently. So welcome to the party. It's great to have you on board. And just to remind you what we're doing, within REMAP CAP, it is studying the whole of community-acquired pneumonia, but right now we're really focusing on the influenza. And so there are 3 domains within the influenza stratum that are important. So remembering each domain is almost like its own trial, but we get these efficiencies by putting them all into one platform. There's the antiviral domain, which is looking at the effectiveness of oseltamivir, baloxavir, and the combination of the 2 against no antiviral as well. And just to remind you that we have the support of Chris Whitty as the UK Chief Medical Officer, and Lucy Chappell as the Chief Scientific Advisor to the Department of Health, that this is an important question, and it's acceptable to randomize patients within the trial to this domain. We're also asking questions around steroids and whether they're effective or not in influenza. There's always been a lot of concern around the safety of steroids in influenza. I think the evidence is supporting more likely that they could well be beneficial, but we need to generate that evidence. So we're comparing dexamethasone versus no steroids, And for some places that we've got hydrocortisone, but that's in the ICU only, and that's been going a long time. And then similarly, we've opened up the immune modulation domain. So testing those immune modulators that we saw were effective in COVID, again, only in critically ill patients. This is in the severely ill patients, tocilizumab and baricitinib. And the tocilizumab is now available for you to order at your sites. So just quickly, I'm not going to spend much time on it because hopefully you all know it, but just go reminders that each domain, because it's almost like its own trial, it has its own inclusion, exclusion criteria, as well as the overall platform. And it's simply patients who are flu positive and in hospital are eligible for the antiviral domain. There are some time limits. We wanted to make sure we treat people early in their hospital admission. And also, they can't have been treated with antivirals already. I know this is probably the hardest one to consider for the inclusion, because many patients have already been treated with these drugs because certain guidelines have recommend that they can be used. The issue is we know that they can reduce symptoms in the community. What we don't know is whether they improve outcomes for patients in the hospital. So identifying these patients early is key before they've been treated, really is ideal, because there's no point randomizing patients who've already been treated. In our mind, that you're never going to get an answer about different drugs if they've already had antiviral treatments. The steroid domain is just slightly sicker patients. Obviously, we're giving the drug for its anti-inflammatory effect, and so we expect it will only be beneficial if there's some degree of inflammation in the lung, some pneumonitis, which we're showing that the patient needs to be on some level of oxygen, any amount of oxygen, but then they would be eligible for randomization to the steroid domain. And again, very few exclusion criteria. If they're in ICU, we need them recruited in the first day. And then the only other really likely one is if the patient is already on steroids for another reason. They obviously can't be randomized to a control group, and they would get steroids anyway. But otherwise, most of these patients, if they're in hospital on oxygen, they're eligible for the randomization. So even if they've been treated with antivirals, they're still eligible for the steroid domain. And I think we're seeing more patients coming through this year. Now, it's anecdotal, I haven't actually counted it for sure, but it feels like more steroid randomizations are happening this year. So maybe there are more sicker patients coming in. And then for the critically ill patients, there's the immune modulation domain. So this is that they're in ICU receiving at least some form of advanced respiratory support. So high flow, nasal oxygen, CPAP, non-invasive or invasive ventilation. Then they're eligible. So these are the patients who, have obviously got severe pneumonitis and do these immunosuppressant drugs, immune modulation drugs work. And the exclusions are, again, hopefully not too many. Obviously, if they're already on the drugs, they can't be randomized. If they've got active TB or invasive fungal disease, then obviously there's some concern about reactivating these diseases. But again, that'll be few and far between. And if they're already severely immune suppressed in neutropenic patients, we would exclude them as well. So that was just a quick run through of the trial, where we're up to, the domains that are open. Hopefully all of you know that, and we'll come back to some questions later, but I'll hand over to some of the trial team. We're just going to talk through a few other points. Then, as I said, we'll have some Q&A at the end. So team, who's doing the next bit?
I'll just go through a few other study updates. So as you know, we've had approval for Substantial Amendment 43. We have instructed sites that it's okay to implement the PIS and consent forms, as there's no protocol for specific mentions on them. That we've got the updated SMPCs and extended insurance as well to cover, I think it was immune modulation. So that's all fine. We did instruct sites to not yet implement Protocol 4 and all the related appendices, just because we haven't yet done the training, and we were waiting for the database to be updated, which has now been done. But we do require a process by which we'll be transitioning all the sites over to the updated version of the database and Protocol 4. So we will be rolling out that training, some of it before Christmas and some of it after Christmas. We'll sort of do it a few sites at a time in a staggered way. So we do have a few months to roll this out. So if you just bear with us while we do that. I'm sure you guys are familiar with the recent ECRF issues we had following the update of the database. So I think some of us had issues logging in. One of them was that when sites did log in, when they did switch system as we instructed them to be able to add a patient, that they had some issues. But so the first thing is, if you do get the kitten image come up, that means that you haven't switched. So do remember to click the button. If you have switched and you still get the image on the right-hand side here, then that was related to an IP mismatch issue, which has now been resolved, I believe. If you got the OWL issue, that was before you even logged in. I think that was upon clicking the login link in the first place. That's to do with site IT, so that would require you to request the Trust IT to whitelist the database URL, which has worked for most sites. I think there were a few sites that still didn't work for. If you are still having issues, if you just drop us an email, let us know if you've got any issues when you're logging in or with the login link itself. It's just going on to the consent process and the reminder. This is more just to touch on how to enter the consent on the database, specifically when you get the question about is the patient capable of providing informed consent, or have you gotten consent from a pro-LR or a per-LR? If you answer no for this question, it won't prevent the randomization because it will assume that the patient has no capacity and that there's no per-LR or pro-LR available, and therefore that you're following the delayed consent process. So clicking no to this does not stop the patient from being randomized. If you have approached the patient or the per-LR or the pro-LR, please always enter yes. If they have declined the consent, then there is the next question that will appear, and this is where you can sort of enter that the patient has declined consent. So I think there's just been a few error randomizations because no has been selected to the previous question, and it doesn't actually prevent randomization. If you intend on collecting consent but you haven't done so yet, please just save the page. Again, do not select no, as that won't prevent randomization. Please just save the page and then you can return to it later once you have obtained consent and then enter those details. Just a note about the localized PIS and consent forms. So we are adapting the treatment sections and then we're sending them to sites, and sites can add their local header and their contact details. If you could just remember to send that version back to us so that we have it for our filing. I think so. I can see a hand up. Is that Cynthia?
Yes, hello, it's Cynthia. Just
Hi.
a quick question on the last two slides about the consent.
Yeah.
Because we are doing mainly ward-based for our peds patients. So I assume the slides you showed had to do with ICU because they are taking the deferred consent. Is that correct? Because we are doing consent before we randomize.
Yeah, so I think the issue is if you intend on getting consent and you haven't got it yet, you must save the form, but you mustn't answer no, because if you answer no, it will still assume that it's delayed consent and that you're trying to randomize a patient without any consent in an emergency situation. So it's just a matter of you just need to save the form and come back to it later and enter the consent once you've obtained it, rather than trying to complete it in advance, if that makes sense.
Yes, sorry, just to clarify again. So usually what I have done is I've answered everything, and then where it asks if you're taking consent, I select not yet.
Okay.
And then it saves the document, which means we then don't go ahead to randomize. We approach the patient for consent before we come back and then update the eligibility form. Or should we be, is that correct?
Yeah, no, that's fine. I think it's just that some sites they answer no rather than not yet, and then it still proceeds with eligibility. So as long as you sort of don't select no and then it continues with eligibility and then randomizes the patient anyway, then you're fine. So yeah, it's fine to just save and then come back to it later. Yep. So just a note about the footer of the consent forms and PISs, so that we do have site versioning in addition to our study versioning, which if you do make any local edits to contact details or PI details, if you just remember to update that. So I think we have sent all sites the documents related to IMP. We have received some training logs. I think we're pending a few more from pharmacists. We have had several queries about IMP Pharmacy Guide version 5. So this is still pending. The sponsor currently working on this to add information about the pediatric granules and any other sort of updated information. But in the meantime, we're just working as per the old pharmacy guide. But if you do have any queries, do let us know. So we've had a query about a pharmacy that serves multiple sites. So some trusts have one main pharmacy and several hospital sites. When you do complete the order form, we still need the separate site numbers to be completed on the order form. So you shouldn't just put the site number of the main pharmacy. Because when we enter the details onto the ordering system, we have the sites set up separately. Each site has its own site number. And if it is just one pharmacy, we'll just add the same pharmacy address for all three or however many sites that pharmacy is serving. So the stock will arrive, I think, with the site number already on it, which means that we can't just use it for another site in that same trust. You will have to stick to the site numbers that it's allocated to. Just a reminder about IMP shipments when they arrive. They will arrive with a temperature logger. If we could just remember to switch this off. There are instructions enclosed about how to package and return the device as it's reusable. And then we have the acknowledgement of receipt form, which should be completed and returned to us along with the copy of the consignment form. Just a reminder as well, if you could please let us know when you're ready to switch that intervention on. We can switch it on the database because if you confirm receipt, we won't just assume that you're ready to switch it on, as some pharmacists have a bit of work to do or need to add something to the system or get a prescription ready or something. So if you could just confirm that you are ready for us to switch it on the database. A few other queries and reminders. I think we've had several sites ask if day 1 for swabs is day of randomization. It is. It's not the day after randomization, so it is the day of randomization, and then day 3 and day 7. The current eligibility checklist statement is the correct version to use currently, as we haven't moved sites over to protocol 4 yet, so we don't yet have updated templates for that, so that's fine to use for now. Just a note about if you do have any previous baloxavir stock, this should be used and finished first. It isn't labelled because this was from Roche's commercial stock. You'll notice that the current stock the new stock that you receive is clinical trial labelled, and that's fine. We are aware of that, and that's the right way. I've got a hand up from, can't see the name, I can only see the initials.
Hi, is it me, Emma?
Hi, Emma.
I just wanted to quickly ask, that swab day one is randomization. I think I inputted something yesterday. So, for example, if day 1 was the 1st of December, day 3 would have then been the 3rd of December. Would that be correct?
Yes.
And the database flagged it up straight away to say it didn't seem right. So I had thought I'd done that wrong, and day 1 was the day, not the day of randomization.
Would you be able to send us a screenshot? We can forward that onto our
Yeah.
database team. I think this query was already appearing before, so it might be an old query because we haven't upgraded all the sites yet to Protocol 4. So some of the old queries are likely still appearing for the old version, if that makes sense.
It did let me tick to say this is correct and continue, but it did flag something up straight away saying it's something wrong with the date, and I thought, oh, I've done that wrong.
You haven't done it wrong. I think that's just the old query, which we haven't. We won't be able to get rid of that until we upgrade all the sites to the latest version of the database with Protocol 4. So unfortunately, that will still appear. But if you can just ignore that, and we'll try and close it from our end.
Okay, perfect. Thank you.
It's okay. And just, I think this is the final slide, just a reminder about our closure days. So Imperial is closed from the 23rd of December to the 5th of, we reopen on the 5th of Jan. There will be inbox cover on the 23rd and 24th from Millie as she works at IGNOC, and they're open. And then on the 2nd and 3rd of Jan as well. In between those, we will have emergency inbox cover, and you can feel free to call me on my mobile if you have any urgent queries. Just a note about lab samples, as the labs will also be closed. The last day for them to receive swabs would be Monday the 22nd. So if you could try and send any swabs before that. If you do have swabs after that, you can either put them in the fridge and send them to us when we're open again. Or if you don't have space to put them in the fridge, then we would just advise sites to omit those samples for those patients recruited over that time period. Got another hand up. Oh. I'm not sure who was Diane? No.
I think it may have been me.
Javier, he's written
Yes.
something. His name
Yeah, I've
is
put you on
slightly
the tab.
separate. Maybe Javier, do you want to ask it at the end, or is it?
Yeah, absolutely.
Yeah, and maybe Emma, was yours related to swabs again? Just to,
yes, it was.
Yeah, go and ask your swab one then while we're on swabs.
Is that for ambient? Is that ambient ones that can't be sent after the 22nd?
So normally we wouldn't require sites to put them in the fridge, but because there'll be a delay in posting them to us, then the advice was to put them in the fridge if you have space. If you don't, then you can just miss those samples out.
Okay, so just pop them in the fridge, and once it's reopened again after 5th of January, can send them on then. Thank you.
So I think that was the last slide. Yeah, that was the last slide. And then we could just go on to questions. I'm just reading the chat. Okay, so training requirements for eligibility checkers. We have eligibility assessors training specifically. It's not a long module. It probably takes about 5-10 minutes to complete. That's on the website, and it just means that there's no separate GCP training needed, and we wouldn't need CVs for those people that are just doing eligibility assessment and no other role in the study.
Does that answer your question? Or you got a follow-up?
Yeah, it's just to confirm. I'm just coming back to support the studies. I'm just trying to get up to date because we have a document that it is called REMAP CAP Eligibility Checklist and Statement version 2 that has the 13 GCP principles and then like an eligibility. In addition to that, can you confirm that any doctors or clinicians that are going to do eligibility need to do them slide set that is available online?
Yeah, so like you can print it. If it's easier, you could just print it and put sort of everything together, and then people can do it on the spot if that works better than trying to get them to do it beforehand.
Yeah. And would they need
they will need to sign the delegation log.
Okay. So they will need to sign the delegation log, then obviously that being countersigned by the PI before they can do those assessments.
Yes.
Okay. Thank you very much.
Okay. Are there any other queries?
Ashley, do you want to,
Ashley?
Aisha, do you want to stop sharing the slides and then
Yeah.
we might be able to see people when they're talking? Yeah, that'd be good.
Oh, yeah. Oh, I think I took control. Oh, here it is. Yeah, no, that's fine.
Hi, Aisha. I wanted to ask, like, I haven't had a chance to look at the new protocol, but would they change the eligibility of the patient? So then means like again, eligibility checkers also needs to go through new slides with the new protocol after the new protocol is implemented. Or
Yes, there are slight changes to the wording of the eligibility, but we do plan on doing sessions on that, and then we can do a limited slide set for eligibility assessors again, just as we have done previously for the current protocol. So we'll just update the slide set that's currently on the website to match protocol 4.
Another thing, I have recruited a patient yesterday, but I had to push with the treating clinician. Normally, I will have difficulty because doctors don't want to go for the control arm of antiviral. But yesterday it was different. Yesterday the doctor didn't want to give antiviral because he believed that the patient's symptoms started before 5 days, so it's too late to start antivirals. But then again, I have to the studies also kind of prove that after certain days and Oslamavir might not work, so that's why we need to put the patient on the trial, and we have the control group. So eventually he agreed. I think it's the right thing I did, or I couldn't really
Tony, I
give
don't know if you see that often or if you've got
I
any
couldn't
comments.
give him a rationale because he said I don't. The guidelines say it doesn't work after 5 days of initial symptoms. So why you want to recruit them now? Normally it's the other way around, but yesterday it was
Actually, I think you highlight though this is the issue. None of us know. We can make informed, potentially informed decisions from what we think is likely about the effect, but we just don't have the evidence for this population. Unfortunately, there were never large randomized controlled trials when the drugs first came out in this population. And so I would try and keep it simple. There's uncertainty in all of these cases. It may be too late even by the time they come through the doors of the hospital. It may be too late later. I don't know. Other people still treat very late, saying, well, if you're testing positive and you're unwell, maybe there is benefit. So that's why I would say is we just don't know. There's equipoise. Let's randomize and we'll get the answers. But that way by putting more people in. So yeah, it's tricky. I get that as a clinician. I've certainly treated people very late with this in the past, but now we're trying to just randomize our all-comers that meet the criteria that we have. There will always be different timings, but we have a few to try and treat people as early as possible in their hospital admission. And then, yeah, hopefully eventually we'll get the answer. As you saw, we're at 900 or so now. You probably need several hundred more with the Bayesian design. We have no fixed sample size. We always estimated we might possibly see results about 1,500. So I don't know if it's a very bad winter. We might get the answers this year, but otherwise it might be next year.
All right. So, yeah. Thank you.
There's a question about the breakdown of sites and how many have got no antiviral. I don't know if we have that. Certainly don't know the allocation to the different groups because we have response adaptive randomization, which means that the ratios are not fixed 1 to 1 to 1, for instance. They can vary, and therefore the stats team don't allow us to know those allocations because we might gain some information around which drugs are looking more favorable. So I don't know that. I don't know if we would know with sites. It's not all sites, but there's a reasonable number. We did look at it a little while ago, Aisha. I don't know if you remember.
We'd have to look on our tracker, but yeah, I can let you know.
If I'm pulling it from my memory, I think it was well over half. So it's certainly not all sites have got the control group. But just to remind you, as we said, we got those letters from Chris Whitty and Lucy Chappell supporting that there is equipoise, and it was therefore acceptable to randomize patients, including to the no antiviral. And to remind you, the Independent Data Safety Monitoring Board looked at the data. I think I'm trying to remember back. I think it was either late October, early November. So before these current patients were recruited, they obviously not been included, and they advised us to just continue with the randomization. They had no concerns, no changes suggested to the protocol. So again, just to remind all your clinical colleagues as well, if they're asking around this, the data is being looked at, and no concerns have been raised.
About 40 sites at the moment.
Yeah, 40. I knew it was over half, maybe 2/3. Excellent, thanks. Trying to slightly impact on a tiny subset. Yeah, no, you make a good point, Michael. Yeah, we would get the answer quicker if more people included the no antiviral in. And then we would learn whether it worked, for sure, or not. And then we could all save money, save side effects of these drugs, and also potentially reduce the risk of resistance, which has come up. And that's just remind you why we're doing the flu swabs, is so that we can monitor for emergence of resistance, which is obviously always a concern. Cynthia, do you have a question? I see a hand up.
Yes, I do. Thank you very much. The recent patient.
You're very quiet. I can't hear you. Yeah.
Can you hear me now?
Yeah.
Just, yeah.
Yeah. Okay. So the recent patients we randomized in Barnet Hospital had already been reviewed by their consultants on the ward, and they were going to prescribe oseltamivir. So the discussions went around the domains, because one of our domains was no antiviral. So the question, luckily, when we randomized, it was antiviral, so nothing changed. And my question is, if it happened that we randomized to no antiviral, I strongly believe this parent would have not been happy with the randomization because they've already been told they need the antiviral. So in this case, if they did reject the randomization, do they still continue to be in the trial, or do we remove them?
Okay, so there's a couple of points there. If you have the domains open at your site, sorry, well, the domain is the whole group, and then you have your choices. People have to be randomized to potentially all of the choices you have open at your site that they are eligible for. We can't do it on an individual patient basis. If we did that, we wouldn't have balanced groups that we're comparing about, because then there's a patient choice coming in, and it's no longer, the power of the randomization is lost because people are selecting what groups they have. So people have to accept that randomization to no antiviral is a possibility if they're going to be in the trial, and then you guys select what's appropriate for your site. Obviously, if people have agreed to be in and then for whatever reason they don't follow the protocol, that's a protocol deviation. People remain in the trial. It's an intention to treat analysis. So they still remain in the trial and they should be followed up. You would need to complete a protocol deviation form, so that we understood why there was a deviation, but they would be followed up. Of course, if everybody has a protocol deviation and crosses over to the other arm, again, we don't get the answer, because then everybody looks the same. We haven't got an experiment going on where people have been treated differently. So it's really important that we don't have too many. It would be nice to say we won't have any, but we've got to live in the real world. We all understand there will be occasional patients who do cross over for whatever reason. But so that would be, if a patient is, or parent, if I think you is what I think I heard you say, so presumably for a child, if you know that they're not going to accept being in the no antiviral and you've got the no antiviral at your arm, then they're not eligible to be randomized in that domain for that patient. They could still be in the steroid domain if they still had uncertainty about that one, but you would have to tick that they weren't eligible for randomization at all. We couldn't just select out the antiviral domains on an individual patient basis. I hope that makes sense. Thanks. Any more questions from people? Emma.
Hello, I've just been reading through the amendment documents this morning, and in the protocol, in the inclusion-exclusion part, it says patients who are eligible for only a single intervention at PSI, i.e. all other interventions are contraindicated, they're not eligible for this domain. Does that mean within the domain, if they can, like, so for example, the antiviral one, if they can only have 5 days of oseltamivir, you can't randomize them within that one because you're only going to get one outcome? Or does it mean if they're eligible, they've come in at flu and they're only eligible for steroids because they've already had the 2 doses of oseltamivir, say, they can't just be randomized for steroids? Because I'm a bit confused.
Yeah, no, so it's domain specific. So if you think of each one would only apply to each domain. So what that means is, therefore, it's to sort of say, suppose you were allergic to oseltamivir and baloxavir, you couldn't be randomized because there's only control to be randomized to. It's a way of pointing out that if there was any reason why a patient couldn't essentially be randomized, because if there's only one treatment available in your site or for that individual patient, they can't be randomized. It's unlikely to occur other than by the reasons we've already said. So in a 2-arm comparison, Dex versus control, if they were already on steroids, then yes, that's why they couldn't be included. I mean, we already say Dex is an exclusion, but it's a catch-all. If there was, say, just for instance, think we've got an antibiotic domain that's nothing to do with flu, and if you were allergic to penicillin and therefore there was only one
Other outcome.
non-penicillin, one non-penicillin drug to be included, that patient couldn't be randomized because they're going to get the fluoroquinolone, for instance. So that's why it's there. So don't let it confuse you. That so if they couldn't be randomized to antivirals, that's fine. They can still be randomized in the steroid domain.
Okay, I completely get that. I just thought it was just obvious.
Yeah,
and it was too obvious to think it was that.
And I think we put that in all the domains because of things like the penicillin one, which is probably the best example. You can imagine why that might occur, because the drugs may change over time, so we don't list them all. But we've just said if there was only one antibiotic available, you can't be randomized. Yeah.
Yeah, sure. Thank you.
Any more questions? I'd also pose a question to you guys. We certainly realise, I know it at my own site, identifying patients before they've already been treated is really challenging. I've just emailed our medical directors to ask them the best way we thought we could promote the trial and remind the clinicians to at least consider it. As I said, I know not every clinician will have the equipoise, and not every patient will have the equipoise to be randomized, but just trying to flag the trial early. I don't know if anybody's got any learning they want to share of how they've made it work in their site, how they've flagged the trial, just again sharing amongst different teams. Any thoughts? Charlotte.
Hi, yeah. So at South Tyneside and Sunderland, our director sent an email out to everybody. We've also put posters up in AD departments and AAU, and although we did all of that last year and it didn't really work, it seems to be working almost too well this year, where we're getting lots and lots of referrals, and it's quite difficult to keep up with the demand.
Okay, Charlotte. Well, first of all, thank you so much for. I mean, I saw you guys at the top of the towards the top of the table, so I recognise how hard you're working. Thank you. I think that's it. It's those ways of advertising in the trust that work. It's interesting. I mean, maybe because there are so many patients right now coming in and it's getting busy, that's when people actually rise to the challenge. You know, when the numbers come in, if people are thinking about it regularly because they're seeing more and more patients, the more you do, you know, I accept it gets harder when there's too much workload. But when you're doing things regularly, it becomes part of the routine. And I think that's what we're trying to aim for, is to just get people to think, if the flu result comes back as positive, all right, should they be randomized in REMAP CAP? Let the teams know that need to be involved and then move on from there, rather than think of it as an afterthought. So it's good to see that working. And I'll keep my fingers crossed that you just sustain a steady workflow and don't get overwhelmed. Thanks. Emma.
Just a quick follow-up from that. Are they trial-specific posters that are getting put up in ED, or are they what sites have made themselves?
Charlotte, what did you use? And
So myself specifically, I'm a respiratory research nurse, so we have a few studies that recruit inpatients. So we have our own respiratory posters up in those areas in doctors' offices and things like that. And we're sort of around those areas a lot as well. Making my presence known, which
yeah,
which sometimes is helpful, particularly if people have got questions.
yeah.
Oh, lovely. Thank you.
I mean, if people thought it'd be useful, we could provide a sort of, you know, a generic poster. But I mean, I'm keen that people make it fit their sites. And obviously, your contact details, you'll know how to, you know, to get your teams to contact you. But if we can help in sort of, even if it's just providing the logos or whatever, you know, sort of let us know and we'll see what we can do. Obviously, these are in the clinical areas rather than patient facing.
Only we have a chat in a comment in the chat about a poster too, so that seems to be a common theme.
Just pasted a link to the poster that we do have at the moment for staff. That's on our website if anyone needs it, and you can edit it to adapt it as suitable.
And I saw your comment, Helen, from Portsmouth. Obviously, yeah, if they've already been treated with oseltamivir, at least they were thinking about it. But the other question is, if they're on oxygen, would they be suitable for the steroid domain? Just think about those things. Okay. Any more comments or questions from people? Emma.
Sorry, it is my last one.
That's right.
It's from the amendment again. You know the part about pregnancy and whether you locally exclude them or not. Is that really specific regional, or is that more countrywide? Has the UK got that approval, or is it region?
So it's region and country. Some countries are whole regions, such as Australia. Well, there's Australia and New Zealand. They are two countries. I get that, but so it's also domain and drug specific. So, for instance, the oseltamivir is allowed in the UK in pregnancy, but the baloxavir is a definite exclusion everywhere in the world, in fact, because baloxavir can't be given. So oseltamivir randomization. And just remind me, team, where are we up with tocilizumab in the UK? We don't have that approval yet. Is that right? I just want to make sure I say the right thing.
I don't think we have it yet. I'll have to check because I'm getting confused between baricitinib and
So the baricitinib is a
tocilizumab.
no, but the
Okay.
tocilizumab we were working through, and again, that would be country specific. That most of Europe wouldn't allow it, but the MHRA will potentially, but they needed some further information, which we were going to update them with. We may not have got the approval yet for it, so I think we're still excluded at the moment, but we're working on getting that approved.
And dexamethasone, where are we with this dexamethasone?
So the dexamethasone you can use, so the protocol advises using an alternative steroid. I haven't got the document in front of me, but I think it says prednisolone or hydrocortisone, excepting with changing the type of steroid, but that's in the advice around the steroid domain. So the pregnant patient can be included, but they just shouldn't get the dexamethasone. It was a different steroid.
It's usually sort of prednisolone, I think, isn't it?
Yeah.
Yeah.
I think it says hydrocortisone as an alternative as well.
Right, okay.
But yeah, but obviously prednisolone is fine if they can take stuff orally.
So it's not an exclusion for the UK for the steroid.
No.
Lovely.
And
Thank you.
And these things that they should be set up on the database automatically. So it's not something you have to actively consider at your site. It should be programmed appropriately so that it knows that you're in the UK and it knows what permissions we have. So that's why using the database is the best way to screen patients.
Okay.
Is it, how do you say this? Is it Chidinma at the Royal Free? If you've got your hand up, you're on mute at the moment. Okay, no, microphone's not working right. We'll look for you typing. Anybody else while we wait for typing to come through? Maybe I'll just add, as you said, we're having the new protocol coming through, which we are happy to start before Christmas if individual sites want to take it on. We thought we'd try after Christmas. And then with the whole reason for changing with the database and the CRF is we've simplified it a lot. REMAP CAP has been running in the UK for 7 or 8 years now, and it's the world has changed a lot. We learned a lot during COVID, and we've therefore updated both the protocol and the CRF, hopefully making the CRF simpler. What are the really important data fields we want? How can we capture it more efficiently? So hopefully that will make life easier for everybody when we switch over. But obviously there needs to be some training on that database, which is just, we thought, unrealistic to get all done before Christmas. But if there are 1 or 2 sites who wanted to start, we could do that. And again, the protocol is to try and make it more future-proof. God forbid, but if there were another pandemic, how we would pivot again for that. And again, we've taken the learnings from last time into that to make it better. So just to explain what's going on there. And then, so now I can see the typing when clinicians confirming eligibility when signing off, would they just sign off study task 2, assess inclusion, exclusion criteria? So Aisha, the specifics of what they need to sign, can you add some info?
Yeah, that's correct. If that's the only task they're doing, that's the only task they need to put on the delegation log. So we've got a couple of minutes left. We will need to jump off at 1 because we've got training on protocol for our team by the sponsor.
Okay.
If there's any more questions, just drop us an email if you need any